Hello and welcome to another edition of For the Record. I'm Sean Murphy. Today we chat with the fine folks from Community Health Center. They are celebrating 40 years. First up, we'll meet Mark next, so stay with us. Welcome back to For the Record. I'm Sean Murphy. My guest today for the first segment is Mark Masselli. Mark, along with others, founded Community Health Center, the free clinic, back in 1972. That's an amazing stat in and of itself. It's Mark's first time on the show, so first of all, welcome to the show.
Sean, thanks so much for inviting us here.
40 years of Community Health Center. Let's start by just kind of giving an overview of what Community Health Center is, what CHC is.
Sure. We provide primary health care to special populations. Most people who are underinsured or uninsured, people who work hard, play by the rules, but have no health insurance. And we provide them primary health services, medical services, dental, and behavioral health services. And we do that in sites all across Connecticut.
Now, is that a way, so you're not health care coverage, you're a facility or facilities that provide them services for those that don't
Absolutely.
have them. Okay.
We hire our own physicians, nurse practitioners, dentists, dental hygienists, psychiatrists, and social workers who help people receive their health care, deliver it directly to them.
Now, it should be noted that it's not necessarily an income-based situation, because there are some people who may be typical middle-class people. Maybe their employer doesn't offer health insurance, so maybe they, there are lots of different situations why someone would come to utilize your services.
Absolutely.
Correct?
That's really a good point.
Yeah.
There are so many people who come to us for various reasons. Some are income dependent. They really have no money at all. But a lot of people work multiple jobs, work hard, play by the rules, but might work 10 hours at a convenience store, or work at a Walmart, work somewhere else, and really have no health insurance at all. And it costs them an enormous amount to receive adequate and quality health care, and that's where we come in.
And how do you do that? Do you base it on their income since they don't have health insurance, or is it just a flat rate for everybody who comes in?
Sure.
How does that work?
It's really great. So first of all, we take care of the uninsured, but we also take care of people who have Medicare, who have Medicaid, and some limited insurance. But if you have no health insurance and you're paying on your own, it's really a function of your family size and family income. And then there are flat rates that you'll pay depending on what the service you'll receive is.
One of the things, what I call a buzzword that you mentioned, and it's sort of a reality of this day and age that we're in, and the economy and the recession, is the underemployed. That has popped up a lot now with so many people out of work. Talk about that a little bit.
Yeah, no, we've seen an increase in the numbers of people who rely on the services that we provide, Sean. And, they've worked hard. They might have had a full-time job before, and now they're skimping together with a number of jobs, but with no health insurance.
Since, I mentioned it, since, the economy is what it is these days, do you find that more and more people are utilizing your services because of that?
We continue to grow, but I think the issue around healthcare in America has always been a vexing one. Since we started back in 1972, then as a free clinic, a small walk-up, if you will, to today where we're in 200 locations, from Stanford to Groton up to Enfield, with a full range of facilities and the like. Still sort of a constant problem. America hasn't come to grips with how do we solve the problem of providing health insurance to all of the people who live in our great country.
Could someone who has health insurance, a typical person, could they utilize your facilities if they wanted to?
They do, and oftentimes they do, because while it's a smaller amount, we have the best physicians, nurse practitioners. We really attract the best and the brightest. So people come in. Sometimes those people had been with us before, then got that job, and they just don't want to lose their primary care provider. And they say, you know what, I want to stay with you. And other people hear just the good word about the work that we do. But I'd say 90% of the people who come to us really come around income conditions.
Right. But yeah, like you said, if somebody likes their doctor, they don't care, what the name is on the doctor's business card. They like that doctor, and they're going to go to him no matter where he's at or what office he's out of.
That's right.
So let's go back in time a little bit. What do you say we go back to 1972?
Okay.
Or maybe even before that, because
Sure.
you don't just snap your fingers and it appears.
Yeah.
So let's talk about the humble beginnings.
Sure, and the humble beginnings were really when a group of Wesleyan University students in Middletown and Middletown community activists came together under this banner that healthcare is a right, not a privilege. And the nice thing about it is they did it not because there was a state grant or a local grant or a federal grant. They came together, there was a local pharmacist, there was a community organizer, there were students who just wanted to make a difference in their community, which is really the American way. If you go back to the community chest before the United Way, it was neighbor helping neighbor. Came together, small second floor walk up. While we were in Middletown, you might have been in San Francisco, sort of had the tie-dye on it, what young kids did back then.
Right.
And it was an exciting space. It was a small space, but we provided dental services as our first services, then offered medical care. We had volunteer physicians and dentists from the community who helped us out, and we really started to make a difference. But then as we saw it, we said, well, how do you sustain it? And then we tried to figure out what's the right business model for people. And the free clinic, while it was very important to start off then, it segued into this notion of people really want to pay something. It might even be barter. But there's this sense of pride that people have and say, look at...
They don't want a handout.
They don't want a handout, they want a hand up.
Right.
And really the health center has always been about that sort of concept that people really want to be engaged in their health care in one way or another. And there are people who really have no money, and we understand that, but a lot of people want to participate in, and that's when we move to this community health center model, which is really the sliding fee scale, really opening up to the state and federal insurances that were available to people at that time.
Right. And obviously over the course of time, you kind of see what sort of demand there is and just like what people are looking for and asking for, and you kind of tweak it and you evolve, maybe a little less of this, maybe a little more of that. And it's become what it is today, which is community health services.
Yeah, no, absolutely. The health center has really evolved over the years from those simple beginnings to a very sophisticated organization caring for 130,000 patients across Connecticut. As I said before, down in the Gold Coast in Stamford, all the way up here in the New London, Groton area, up to Enfield, and then lots of other sites. You'll hear from a moment Margaret Flinton, who's a co-pilot of the health center with me, and she'll talk about our Wherever You Are program. But really we said, you can have the hubs, but where's the spoke? So your children go to school, you're busy working, they need to see a provider, we're in the school.
Yeah.
And that's a nice service for so many families. It's a practical one.
Yeah, you
as
come
well.
to them instead of them
That's right.
always coming to you.
Absolutely, it's a very exciting. And then in terms of the evolution, we were the first statewide facility, public or private, to adopt an electronic health record. So probably 8 years ago, we rolled out an electronic health record. And so now all of your records are kept in a way that you can access them as well.
Oh, okay.
Because we give you a portal. So, oh my God, I'm taking 3 drugs. I can't spell one of them. What are they? And you can just go in there and say, that's the drug, that's how it's spelled.
Copy and paste it, basically.
Absolutely. Or you're down at the emergency room, and here we are in the New London area at Lawrence Memorial Hospital. We give the emergency room, with your permission, access to a summary of your records so they can say, Sean had these 3 meds, and by the way, he had this test, we don't need to do it, and I need to make an appointment. Came down here just for whatever it was. We took care of the problem, but they need primary care. Let's schedule it right now, and we allow them to schedule the appointment.
It's a time saver and also a money saver if you don't need that test that you've already had.
Absolutely, and that's the key thing. Electronic health records make it safe for patients and really open up the information to other providers that they're working with. And so we love it, and we've been a leader in it, and we're excited about the patient portal. We have thousands of patients who access the portal. And you might say, by the way, I want that refill. I don't want to be on the phone. I've got a busy thing. Pull out your there's an app for that. Pull out your iPhone. You you can send off the message to us, and that's really trying to make it efficient, effective, and what we say is elegant.
And I know that you're technologically savvy because, we were talking off the air, you got your iPad with you and your iPhone. And yeah, like you said, now obviously the community health centers are networked, so maybe if somebody moves or they're closer to a different facility, then they can go there and all the stuff is there for them available.
Well, we're one organization, we're in 200 locations.
Right.
And so if you were moving to Danbury and you had been working in New Britain, you walk into our Danbury site, it's not about, fill out this record release, we'll get it in 4 weeks, and we'll understand it in between, then we'll sort of figure it out. No, it's right there, it's immediate, it's fully accessible on it, and so that really helps people out. That's why we're a little different in what we're doing as a community health center. We believe for Connecticut, there should be one community health center. Not that there won't be others in your community that are smaller and provide great services, but there's one, so as people travel around this state, that we can provide them with quality care, comprehensive care, and care that's accessible wherever they might be.
That leads me to my next question, which is how do you, and the way you speak so eloquently, I think you could, sell this to anybody. How do you get the best doctors and people in the medical field to be a part of community health center? What is it that you say? What do they buy into that they're liking, that they're agreeing with?
It's a great question, and really it's about the organizational design of the health center. So most organizations who provide health services are just a provider of health care, and we believe you've got to provide excellent health services. But the other two pillars of the health center, one is research and innovation. We are saying if you're going to be engaged in the work of primary care, you got to figure out how to improve it. So we have all these research projects, and not the ones that people are probably thinking about, they do the test of the drugs. No, it's about how do you improve the delivery system on diabetes, on asthma, on hypertension. What's the work that could help improve the delivery of those services? And so we have improvement and implementation research going on. And then, and Margaret will talk about this in a little while, training the next generation of health professionals. First in the nation nurse practitioner program and a postdoc resident. So if you're a provider and you're going into primary care, first of all, it's a slog. It's not easy. Not like a specialist, and I don't want to criticize specialists, 9 to 5.
They have their needs.
And they're very important, but primary care is very engaged in the community, very engaged in the patient. It's a complicated work, and it's demanding. But they come into an organization where they could also do research or they could train. And as you get older, you might say, you know what? I'll take 10% of that, I'll take 10% of this. And this is a type of organization that's a learning organization. So if you're out of Yale and you're chief resident, and we have many of them who've come to us, or out of Columbia, you're saying, I want to be engaged in this work, but I also want an organization that's thinking about the future, one I can grow in. And if it was that easy, we'd all be healthy in primary care. We know, even the health center, we have our limitations. Not everything goes right. And that's why we're engaged in this pursuit of research and pursuit of training the next generation of health professionals to the model we've developed.
Got to take a break.
Sure.
But I just want to ask you one quick question. It's almost more of an opinion thing. The state of healthcare in this country, is it a hindrance for you and your ability to do the work that you do? Do you agree with it? Do you think there could be some tweaks? And how can it help you? Or what do you think?
Well, I think the first thing, and I think the new Affordable Care Act, and I know it's controversial, but I say, when I talk to my friends in the business community, we can't compete in America against Europe and so many countries.
A very different model.
Who have health insurance covered. And you think about the businesses who are the startup businesses, who have their friends working with them, who have to say, look at, Sean, it's $20,000 to pay for your health insurance in your family, or I could put it into the business. It's not that they're mean-spirited.
Right.
They're just trying to figure out what we do. We have to, as a country, resolve and solve this problem about access to health care. And I know people, what they're feeling about the government is, but this is one of the roles that government does play. It's got to figure out how to do it, and then let the free market work. And so I think we take a big step with the Affordable Care Act on coverage. That's very important. I don't think about it in political terms. I think about it in economic terms. It's going to unleash a lot of small businesses, and that's what America is. We are a small business country, even though we have big corporations.
Right.
The heart of America is those small chamber of commerces. We need to make sure people have the ability to do the work that they want to do. Giving them health insurance is very important.
We kind of cut into Margaret's time a little
Okay.
bit here. I want to have you give a website out so people can go and learn more about Community Health Center.
Thanks so much, Sean. It's www.chc1, and that's the number one.com.
All right, we'll put a graphic up on the screen too. Mark Masselli, thanks so much for being on the show.
Sean, thank you so much.
We'll take a short break and be back. I'm Sean Murphy. This is For the Record. Stay with us. Welcome back to For the Record. I'm Sean Murphy. My guest this segment, Margaret Flinton. She's Senior Vice President and Clinical Director of the Community Health Center, also a family nurse practitioner by profession, also first time on the show, so welcome to the show.
Thank you very much, Sean.
We had such a good time chatting with Mark in the first segment, and I know we're just going to kind of really almost sort of continue the conversation we had about CHC and really where you'd want to go to kind of continue that. Some other stuff that we didn't get to in the first segment, so it's your choice basically.
Sure. Well, thank you. That's a nice open invitation to
You're
talk
welcome.
about a subject of great excitement.
Yes, and I know that you guys
are
very passionate about it too, which makes it exciting. So
we are, and certainly one hopes that if you're going to do your life's work, you're going to do it someplace where you are excited and passionate. And I think that characterizes the 700 or so people that work at the Community Health Center or who have spent part of their careers with us. Some of them are in training, some of them practice for a lifetime, some with us for just a few years. But I thought you had a great overview of what a community health center is, what's different about this community health center, and I thought I would expand a little bit upon that for you. And Mark used the expression wherever you are, or WIA for short, as we call it, and I think it's a great example of how a community health center is both similar to perhaps the practice that you've always gone to for healthcare and how it's really different. We realized years ago, even with having primary care centers in 13 cities and Connecticut, that not everybody could access care, even with us being in those neighborhoods and communities, and that we really needed to go to them, go where the patients are. And where are they? Well, when you look at kids, certainly a population very important to us, whether elementary or high school, they're in schools. Today, we deliver dental care in over 200 schools in Connecticut using very sophisticated equipment that can be packed up, unloaded, x-rays, hygiene visits, sealants, to try and really move the needle on the percent of kids who are simply never getting routine dental care. And you know what happens then. You're left doing painful and difficult restorative care. That's an example of meeting a particular, very specific clinical need. But for 20 years, we've been running school-based health centers in schools, more than 20 schools in Connecticut, a nurse practitioner, a full-time behavioralist, as well as the mobile dental services, so that moms and dads who maybe don't get paid when they have to leave work and take the child to their primary care office because the child had a sore throat or an earache, the school nurse doesn't have the authority to say you can or can't stay in school, they don't have the diagnostic tests available, so we're able to do those things right in the school. And when you look at the difference we've made there, I would say certainly the issues we have had traditionally about access to care for behavioral health, in particular for uninsured children or low-income children, we've really met those head-on in many schools. And the last place we go is homeless shelters and domestic violence shelters, where people experience probably the greatest barriers to care of any place. So while in total numbers, those numbers are relatively small compared to our entire 130,000 patients, as Mark told you, this is the definition of a vulnerable population, right?
Absolutely.
When you go and you're able to deliver really comprehensive primary care, we do the same thing in a small licensed facility that we do in our beautiful big facilities that Mark described to you.
You know, one of the key things you said is, and this is so true, is if you have to travel a place, even if it's around the corner from you, it is less likely that you will visit the doctor's office as opposed to talking about the school. If they come to the school, the child is already there, even if it's after school or in the middle of the day when they've blocked away some time, that child will get services provided to him, and there's a chance that he will not, if the parents make an appointment, maybe they're at work, they can't, even if it's right around the corner. So you're again, you're bringing it to them. That's
right, and you actually raise a great point, which is how do we think creatively and out of the box about how do you eliminate waste, waits, and delays, three things that we just abhor at the health center, and we've taken this to some new levels. One of the big challenges we have is how do our patients get to specialists, right? They're here for primary care. We do virtually everything except the most unusual and complicated conditions, but we often want a consultation. You know, the person who has hypertension and diabetes and asthma, and maybe they're suffering depression, and we've maxed out the medications. Things really aren't going right. We really need a consultation. Well, traditionally the answer's been we have to send you to the specialist. But with a lot of those conditions, you don't really need to send the person. You need to send the problem, the information, the diagnostic images, the history, the lab tests, and you need an expert opinion. So now we're piloting, we call them e-consults.
If you've already done the tests at your office, then why does a person have to go to the other place, the specialist?
Well, because what we need is the expert, brilliant opinion of that specialist, somebody who sees thousands of people with the condition that maybe we're only treating 150.
Right.
We think this is the way we really build primary care and also help primary care be as satisfying a career for providers as possible. Access to expert opinions that are beyond their immediate expertise or scope when they need it, and for patients, again, not taking another day off from work, not traveling a long distance, not having to go through the whole process of registering and sharing the information all over again. The third thing that makes this possible, and really goes back to the homeless shelter or the schools or e-consults or our being a national leader in some areas, is making technology your friend in healthcare. We couldn't do this before we had electronic health records.
Yeah.
Maybe we could have faxed things over and maybe they
still
wouldn't get lost.
And ponderous,
but now to be able to put it in a, we call them a P2P communicator from our system to yours, and the answer back in 48 hours. That's very exciting. It really changes the dynamic, and also allows us to, as we begin to train the next generation, and I know you want to talk about that a bit, really show people new models, new ways. Of course, doing research and evaluation to make sure they really work, that you get the quality outcomes. But this is some of the excitement that we think we can bring to primary care.
You know, technology and advancements in that, it's not only beneficial for medical purposes, but also for your staff to be able to do their job, and that makes the patients, time there more enjoyable and quicker, and it's just a win-win. Technology advancements are just win-win for patient and all the fine staff of Community Health Center.
That's right, and nationally, the whole agenda that's been laid out really over the past 2 administrations has been get everybody to what we call meaningful use, not just having an electronic health record that turns your old paper chart into a Kindle, or the equivalent of a Kindle, but really meaningful use. How can I make it so that when I call our primary care provider at night because I really think this might be an emergency and they send me to the emergency room, my information can be at the ER before I even get there. Those things really save money nationally in the healthcare system. They certainly reduce costs and they improve safety, and those are all our goals.
I do love the fact that, we were talking about Mark's iPad and the fact that you can have apps on it. Obviously, you need to be somewhat technologically savvy to be able to utilize it, but more and more people have them on their smartphones every day.
The apps are getting pretty dummy-proof.
Yeah, they really are. Push button here,
That's right.
And that makes life easier and simpler for people too. So again, just add on to, making the experience enjoyable, and someone will certainly want to come back after having a pleasant experience.
Sure.
The needle doesn't help, but what are you going to do?
We haven't. A few things have been virtualized, but not injections. But I wanted to tell you also a little bit about what we're doing about the next generation. And Mark really spoke to this issue of clinical excellence in everything we do. We have a model of care, and we are sticking to it. We borrow from other people, from the research, but really have organized our care in a way that addresses both prevention and health promotion, wellness, how to manage all the chronic illnesses, and also, of course, deal with the acute things that come up in all of our lives, no matter what good health habits we practice. That's really the definition of primary care, right? So we pursue that clinical excellence in everything we do. Mark also talked about research and innovation. We started the Weitzman Center several years ago at the Health Center, really to be the place where we can conduct formal research as well as what we call kick the tires research, try out a system, see if it works, improve it, make it better, hopefully share the results of that. But the third is around training the next generation. We are very passionate about what we do. We think we might do it till we're 110 years old, and everybody else at our staff might too. Right. But realistically, if we don't do something about the next generation of healthcare providers who come after us and healthcare leaders, it's kind of been selfish with our resources. So we looked at what was really missing in the country and said, residency programs for physicians have been out there for a long time. They're increasing. They're excellent. They do a great job. Residency programs for dentists are out there. But the group of primary care providers who've not had access to residency training, which is funded really at the federal level through Medicare, are nurse practitioners, yet they play a vital role as primary care providers. across the country. And in the setting of community health centers, where the care is very complex and patients often present having had no access to health care for years, we're dealing with a whole host of clinical and social problems, we really ought to provide a formal, intensive, postgraduate, one-year residency training program that trains people both to clinical complexity, but also to the model of care. And so we started the first one in the country in 2007.
I'm going to have to pause you right
Sure.
there because Mark took most of your time.
Oh, he did.
So we're going to have to end it there. We're going to put
Yeah.
the graphic up on the screen one more time so people can go to the website. Margaret Flinton, thanks so much for being on the show.
Thank you so much for having us. We really appreciate being here.
And thank you for joining us for another edition of For the Record. I'm Sean Murphy. We will see you next time. Take care.